Have you ever thought, why do I not feel like myself? Not just tired, but wired and exhausted, sleeping but not recovering, feeling anxious, foggy, irritable, sweaty at night, or suddenly dealing with symptoms you just can't explain. And then comes the most frustrating part. You try to talk about it and you're told that's just stress, or welcome to getting older. But what if it's not just life? What if your body is actually giving you a very clear message? Today we're breaking down menopause symptom management, perimenopause, menopause, and postmenopause, and what your options really are, from hormone therapy to non-hormonal treatments, to what actually helps and what's just hype. I'm Vita Urbonis, and this is Understanding Menopause, where we replace confusion with clarity. Let's get into it with an expert from the CU Anchutz College of Nursing.
And joining me now is Dani Balinski from the University of Colorado College of Nursing. She is a certified nurse midwife, also a Menopause Society certified practitioner, among other things, an instructor as well. You have a lot of hats over there.
Definitely.
Thank you for joining me, Dani.
Of course. Happy to be here.
Okay, so today we are talking about symptom management for menopause. Perimenopause, menopause, and postmenopause. And you're going to break it all down for us because there's a lot of information.
Yeah, definitely.
Okay.
I think the first thing that we do when we sit down with someone who comes in for menopausal symptoms, kind of wherever they're at along their transition, is get a really good history and figure out, what are the things they're experiencing and kind of what is the most bothersome. It's also important to think through, are there other things that could be causing the symptoms that they're experiencing? We want to make sure that, mood symptoms aren't related to like a new onset anxiety or depression. Could you have diabetes? Is your thyroid off? Could you have sleep apnea? Are you taking medications that could be causing side effects? Sometimes people will present with like, irritating vaginal symptoms or vaginal dryness. Could there be infection? Anything like that. So we're taking a really thorough history. We're ruling out kind of other causes of what could be going on. And when we sort of dial into, okay, we do think this is something going on with your perimenopausal transition, or if you are already postmenopause, then treatment options are really going to depend on where you're at and what we think the cause is. So the most, I guess, common things that we are treating are vasomotor symptoms, so night flashes, hot sweats, as well as concerns about, menstrual irregularities, sleep disturbance, mood concerns. And for that, we have options to use hormone therapy, and we also have a number of non-hormonal options because there are some people who are not able to use hormones if they have certain medical conditions or have had certain things in their medical history.
There's a lot of talk right now these days about hormone replacement therapy. How should somebody kind of start their conversation with their nurse, their midwife, their doctor about menopause?
So I think coming in and explaining, where you're at with your bleeding, we're going to kind of look at how old you are and what symptoms you're having. In terms of hormonal treatment specifically, there are 3 FDA approved reasons to use hormone therapy, and those are moderate to severe vasomotor symptoms, night flashes, and hot sweats, the prevention of osteoporosis, specifically in postmenopausal women. And we also have a topical vaginal estrogen that we use for treatment to moderate to severe vulvovaginal symptoms. And what that means is like vaginal dryness. Sometimes people also describe kind of like weird, like feeling weird when they're going to the bathroom, almost like a UTI type picture, but they don't actually have a UTI. And so those are the 3 like FDA approved reasons that a clinician would be using hormone therapy. That said, we've talked about a lot of the other symptoms that people will report improvement on, but those studies have either been mixed or there just isn't enough data for the FDA to approve hormones for those indications. So if someone comes in and we are saying, yes, we've kind of ruled everything else out, it makes sense that the symptoms you're experiencing are related to your menopausal transition, and we're going to look at using hormone therapy for treatment. The next step is to understand the risks and benefits so that a patient can make an informed decision. And the risks and benefits are actually going to really depend on any given person as well. Reasons that we would say that it would not be safe for someone to use hormone therapy would be if someone had known, suspected, or a history of breast cancer or another estrogen-dependent cancer. If someone has a history of having a blood clot, either in their lungs or their legs, active or recent, stroke, heart attack, some liver disease. If we think that someone could be pregnant, this would not be a good option. Or if you have like a known allergy to either estrogen or progesterone, then obviously this wouldn't be a good option. And then we're also going to talk about if patients have what we would call like a relative contraindication. So if someone has high blood pressure or smokes or has migraines with aura, which means like weird flashing lights, obesity, diabetes, thromboembolic disorders, which would mean issues with clotting your blood or gallbladder disease, then we might have a longer conversation about, oral versus transdermal treatment, just to make sure that any given person is safe.
Okay, so what role do estrogen and progesterone play in menopause? And there might also be a testosterone element in there too.
Yeah, so as we're going through our menopausal transition, hormones at first can sometimes be a little bit erratic, but as you get closer to that final menstrual period and past, your levels of estrogen and progesterone in your body are going to be quite low, as well as testosterone also declines over time, but it doesn't have the like precipitous drop that estrogen and progesterone do starting about a year or two before that final period and then continuing on. And so the reason that estrogen in particular works to alleviate some of these symptoms is that it's just kind of like adding back so that you're maintained at a level, and this level's kind of different for everyone, to prevent you from having hot flashes, night sweats, those sorts of things. And we can extrapolate based on like the dose that we know you're on, kind of where about your serum estrogen levels might be. But there isn't necessarily like a target in terms of you have to be at or above a certain level to have symptom relief. It really depends on the person. And so sometimes we have to titrate, up or down based on how people are feeling, because people can also feel not their best if we give them too much of their hormones back. People can have breast tenderness or might have like heavier bleeding if they're still having a cycle, things of that nature. But it's not restoring, people who are using hormone treatment for menopause, it's not like this is restoring your ovarian function. Like we're all still going to go through menopause as long as we live long enough. However, this is a really good option if people are having bothersome symptoms, and also has the added benefit of like preventing bone loss and lowering risk of a fracture.
So I know that a lot of people think that hormone replacement therapy is the only treatment for menopause, but really you say there are a lot of options out there for menopause symptoms and managing them.
Yeah, certainly. We have a number of hormonal options as well as non-hormonal options, and what we use and when can kind of depend again on a person's medical history and whether we think that it's safe for them to take hormone therapy or not. For the majority of healthy people within 10 years of their menopausal transition, it is an option. But for someone who has like a personal history of breast cancer or maybe a strong family history and would prefer not to use hormone therapy, we do have other options, which is great.
Let's talk about those other options. What's out there for people?
In terms of hormone therapy in particular, there are actually quite a different number of options even within that. So generally, we are using some form of estrogen therapy. If a patient has had a hysterectomy and no longer has a uterus, they don't necessarily need to use any sort of progesterone. But if someone has a uterus, they do, because estrogen, what it will do by itself is potentially build up the lining of the uterus. And if we don't oppose that with the progestin, that increases the risk for uterine cancer. So that's one important consideration that we always look at kind of right off the bat. If someone's main concern is like the genitourinary syndrome of menopause, which is again that vaginal dryness and irritation and things of that nature, there's also an option to use a local estrogen therapy that does not increase serum levels of estrogen. That is very safe and generally doesn't have contraindications because it's not going into your blood. We also will sometimes, and we don't always think of this as hormone therapy, but birth control pills are hormone therapy. And depending on if someone might still need birth control, if someone is earlier in perimenopause and still has a risk for getting pregnant, or especially if they're having abnormal cycles, bothersome bleeding, sometimes birth control pills, because they are a overall like higher dose, than what we use in HRT, can actually be a better option to control some of those other like bothersome bleeding symptoms.
So we talked about HRT. You're talking about birth control for perimenopause.
Uh-huh.
What about
And
what about birth
then I
control for
think
menopause? Do we have? I mean, or is that a time where you don't want to be going on birth control for the menopause?
so usually once people are past like 52, 53, because the dose is higher and the majority of like birth control pills we use are oral, the kind of like risk benefit for some of the like scarier things like the stroke and the blood clots are higher. So if someone is like happy on their birth control pill and they get to 52, 53 and we think they're kind of starting to go through menopause, I will titrate them down to like a lower dose birth control pill and then a higher dose hormone therapy, and then kind of go down to like kind of see where they land.
Okay, so you want to go gradual. You don't want to just like boom, boom. It sounds like
Yeah,
you
because
want to taper your
that'll
body.
that'll give someone hot flashes. Like if
Okay.
they're used to
Oh,
being maintained at a certain level and then we drop it all of a sudden.
well,
Right.
okay. So with those treatments, what are kind of the therapeutic benefits that go alongside of them?
Definitely. And so with estrogen, the main therapeutic effects are treating hot flashes, night sweats, vaginal dryness, and also preventing bone loss. And I have a lot of patients tell me that they also feel a good effect with brain fog, joint pain, and sometimes just feeling a little bit more like themselves, which is awesome. Some side effects, and these are things that we kind of look at to be like, did we go up a little bit too high on the estrogen level for you as a particular person? If people are having like nausea, breast tenderness, some more like low mood or mood changes that kind of almost feel like PMSy, worsening headaches, or if we are seeing like changes in vaginal bleeding or, heavier bleeding. Sometimes those are signs that we might need to actually go down on the dose. So it can be a little bit of trial and error. In terms of the progestins, we have, depending on the formulation you're on, you might be taking like a progesterone orally, or sometimes there are like synthetic progestins that are in some of the patches that we will sometimes use. And the benefits that people will report is a lot of times these help with sleep. And so we'll have people take them at bedtime. However, I do have some patients that have a really hard time with progesterone. It either makes them like too sleepy, or they feel like it affects their mood. Some people will report like dizziness or bloating. And so sometimes we can even recommend, for example, like a Mirena, like a hormonal IUD, to protect the uterine lining and prevent someone from having to take additional progesterone with their estrogen. So there's a lot of ways to kind of like tailor it to the person depending on it. Is it helping their symptoms, or are they also experiencing side effects?
Some people like to add a topical testosterone because women also have, it's a lower level than men, but women, as part of our makeup, we do have testosterone in our system.
Sure, definitely. And as we were discussing in another segment, testosterone does not drop quickly in the same way that estrogen and progesterone do at the, a year or two before and through menopause. The kind of peak testosterone levels that women have is, puberty and, 18, 19, 20 years old. And then it is kind of a gradual decline over time. The only kind of like approved FDA approved use for testosterone is for hypoactive sexual desire disorder, and there's not a lot of data for using testosterone for any other like symptom or condition. That said, I do have patients that want to try it just for, kind of general well-being and energy and those sorts of things, and as long as we think it's safe for you, we will help with that, but we would want to dose this to be a female dose and not a male dose. And the reason for that is if we accidentally dose testosterone too high, we can have like irreversible masculinization. So that would be like deepening voice. People can have clitoral enlargement, receding hairline, hair loss, hair growth, starting to have like, a little baby beard, acne, things of that nature. So this is one area where we will actually test your baseline testosterone level and make sure that being on it, you're not getting levels that are too high that would potentially cause some of these irreversible changes.
And I know we're going to discuss HRT a lot more in depth in our next segment, but are there any natural or other lifestyle-based ways that can ease some of these menopause symptoms?
The answer is kind of yes and no. So we know that like complementary and alternative therapies are very commonly used. Studies tell us that there's something around 50% of people will try some sort of like complementary or alternative treatment. However, there isn't a lot of data to suggest that these things work, especially compared to like the standard treatment, which is going to be the estrogen. Some things that people will sometimes use would be like phytoestrogens. So that would be food or extracts like soy, red clover, flaxseed. These are kind of weak estrogens that come from food sources. They're generally safe and they might have like a modest benefit in treating vasomotor symptoms. Sometimes people will also use other botanicals like black cohosh or chaste tree berry. Both of those have kind of conflicting evidence to whether they are effectively treating menopausal symptoms. So if people feel strongly about trying them, I just definitely recommend letting your provider know anything you're on, even if it is not technically like a medication, but a supplement. And things that have maybe a little bit less data would be like evening primrose oil, vitamin E, again mixed, it might slightly reduce hot flashes. Magnesium is a common supplement that doesn't help so much with hot flashes, but might help with sleep, which again, we've talked about how that can improve function just by itself. And then there have been some interesting studies on acupuncture, which are also kind of conflicting, but some did show some benefit, and acupuncture is safe. However, it is often quite expensive. So yeah, kind of a mixed bag in terms of the complementary and all alternative treatments. But we do know that it is something that people will often be trying on their own. And so definitely a good thing to bring up to your provider.
What other non-hormone replacement therapy treatments are out there right now?
Good question. And as I mentioned, there are some patients for whom which hormone therapy might not be safe or recommended, as well as there are some patients who, for personal preference or otherwise, just prefer not to take them. And so luckily, we do have several non-hormonal options that have been proven to improve hot flashes. One of the classes that we have commonly used for a long time is SSRIs, or selective serotonin reuptake inhibitors. Some of these are dosed just at bedtime, and if you're also, experiencing distressing mood symptoms, sometimes these are also medications that we use for depression and anxiety, so that can be like a good double benefit. We also have a new class of medication called a neurokinin 3 receptor antagonist. Victoza is the trade name, and that is because it is a newer medication, not always as well covered by insurance. Like we might have had to try a couple other things or document, for example, that a patient isn't able to take hormone therapy for X, Y, or Z reason. But it is really exciting that we are having more options come on the market for people who are not able or prefer not to take hormones.
There's a new FDA-approved drug for women who cannot take hormone replacement therapy, and it's supposed to be helping hot flashes. Dani, can you give me some insight on this?
Yeah, definitely. We're happy to have another treatment option for those vasomotor symptoms, hot flashes, night sweats. As we've been discussing, those are incredibly common. About 80% of women going through their transition will experience them, and they can be quite bothersome and last for as long as a decade for some people, and we know that hormone therapy works quite well. However, if it's not an option due to, for example, a breast cancer diagnosis or another contraindication, or someone just prefers not to use it, it's awesome to have another option. And so the medication that is on the market now is called Veozah, and it works actually in the brain by blocking what's called a cispeptin, neurokinin B, dynorphin, or also a candineuron. And we know that this will decrease the frequency and severity of hot flashes for people who are otherwise unable to take estrogen. So awesome to be, living in a time where we've got some more treatment options for folks. Again, meeting with your individual provider to figure out what is going to be most appropriate for you and your body.
All right, Dani, thank you so much.
Before you go, the next episode is a big one. We are talking about the evolution of hormone replacement therapy and the moment everything changed. The study that made headlines, scared millions of women, and reshaped how doctors talked about hormones almost overnight. What did that study actually find? And what do clinicians say now? With years of newer data, updated guidelines, and clearer understanding of risk. If you ever wondered whether HRT is safe, who it's for, and why the conversation got so confusing, you do not want to miss the next episode. Subscribe, follow now, and I'll see you there.